I'm Dr. Laurence Sperling. I'm a professor of medicine and cardiology and the director of the Center for Heart Disease Prevention at Emory University School of Medicine in Atlanta, Georgia, U.S. I'm also the current president of the American Society for Preventive Cardiology. It's a pleasure to be here. I just presented at the 20th World Congress on Heart Disease in Vancouver, Canada. The talk I gave was titled Cholesterol Goals and Targets. Can we improve them? And really, I purposely changed the title of my talk for today, and it was focused on opportunities for improvement based upon a paper that was just published that we wrote in the Journal of the American College of Cardiology that was published this past week. In my talk today, I focused on the ACC-AHA 2013 blood cholesterol guidelines and highlighted how these guidelines now are a new opportunity for us to rethink how we do what we do and why we do what we do, and most importantly, that they are very patient-centered. And they're focused on really what is a meaningful discussion between the patient and the clinician, and that our guidelines are not necessarily biblical, that they're a starting point, but we certainly can still use our clinical intuition, we can use our clinical experience, and most importantly, we should take into account the patient's preference, their treatment goals, and what it is they're trying to achieve in the overall care. The other thing I pointed out was that these guidelines are based upon emphasizing the benefit to risk and side effect ratio, and that there are clearly 4 treatment groups that appear to benefit from statin therapy. Those with known ASCVD, those with LDL cholesterol greater than 190, those with diabetes, especially with other risk factors, and individuals with a 10-year ASCVD risk greater than 7.5%. In my presentation, I went on then to highlight a study that was just published recently in the New England Journal of Medicine, the Improve It trial, 18,000 patients, post-recent ACS, in the past 10 days. They were randomized to a moderate intensity statin group with simvastatin 40 versus simvastatin plus ezetimibe 10 milligrams. And they were followed looking at a combined endpoint of cardiovascular events. After about 5 years or so, this was a large study, but it did demonstrate a significant reduction in events in those treated with combination therapy. A 6% a 6% relative risk reduction and a 2% absolute risk reduction with a number needed to treat of 50. I pointed out that this study clearly will change our next set of guidelines, and we will certainly want to pay attention to the Improve It data. But lastly, in my presentation, I emphasized opportunities for improvement in terms of the approach to the care of patients at risk, improvement in terms of delivery of comprehensive care in terms of cardiovascular prevention, and I highlighted 4 areas. One is improving utilization of proven therapies and adherence to these therapies. I emphasized that unfortunately we're not doing a very good job in even delivering the very basic therapies post-acute coronary syndrome, and those include guideline-based statin therapy. I also emphasized that opportunities for improvement of use of cardiac rehabilitation, which a recent paper in JACC showed that our referral rates are at about 60%. Now that is just referral rates. That's check the box, cardiac rehab recommended. But it is important that we understand that there's a process involved with getting patients not only referred to cardiac rehab, but getting them enrolled, participating and completing, and each step of the way there's data that shows us that this correlates with their outcome. We know that hospitals that are typically academically oriented or see a large number of patients with myocardial infarctions have a greater rate of referring their patients to cardiac rehabilitation, but this is clearly an opportunity for improvement. The last 2 areas where there's opportunity for improvement include identification and treatment of individuals with familial hypercholesterolemia. I call this a disorder hidden in plain sight. There's about 1 in 250 to 1 in 500 individuals have familial hypercholesterolemia. This is worldwide. In the US, only about 20% of these individuals are identified, unfortunately. And so there are over 600,000 people in the US with familial hypercholesterolemia. There are major efforts underway through the FH Foundation to improve identification, awareness, and treatment of this population, and then focusing on appropriate cascade screening to identify their first-degree relatives at risk. Lastly, an opportunity for improvement is focusing on the disease process of atherosclerosis itself. I highlighted that there are trials underway looking at disease-modulating therapies, antibodies directed at the interleukins, looking at TNF-alpha modulators, and also even methotrexate therapy at a low dose to improve potentially the risk of vascular events. There are also new drugs that we have available that are recently FDA approved. One is called lomidopide. There's an agent called mipamycin. And just yesterday, the first PCSK9 inhibitor, alirocumab, was approved for use in the United States in individuals with familial hypercholesterolemia. If we look in total, the new cholesterol guidelines from 2013 will be a starting point, and they will be continued to be revised as high-quality scientific evidence allows us to. Importantly, though, and high-quality evidence includes the Improve It trial, which I think will be incorporated and integrated into the new guidelines. Importantly, though, there are significant opportunities for improvement in the delivery of comprehensive preventive cardiovascular services. This is a place where we can make great strides, and I think it's key to, as we move forward in the world of cardiovascular care and prevention, we need to realize that there's science, but there's also care delivery that focuses on our patients and healthcare systems.